How's it going, guys? We have a medium difficulty question for endocrine biochemistry. Before we get started, please subscribe to my channel. I really appreciate it. Give the video a like, really appreciate it. 7-year-old boy, he's got obvious diabetic ketoacidosis here, polyuria, polydipsia, vomiting, sluggishness, super elevated glucose. What's most likely to be seen in this patient? Choice A, decreased beta-hydroxybutyrate. It's wrong. It's going to be increased. Beta-hydroxybutyrate is a high-yield ketone body. It's the one USMLE focuses on. So if you have deficiency of insulin and DKA, then the cells can't take up glucose. They're going to be forced to engage in gluconeogenesis and ketogenesis. So for ketogenesis, you're going to cleave fatty acids down where you liberate acetyl-CoAs, and those can be merged together, ultimately form acetoacetate, which can go to ketones, okay, like acetone, beta-hydroxybutyrate. So it's an up arrow for beta-hydroxybutyrate and DKA. Wrong fucking answer. Choice B, decreased serum sodium, correct answer. It's called dilutional hyponatremia when you have super elevated serum sodium. Fuck am I saying? When you have super elevated glucose in the blood, that's going to act as an osmole, which is going to pull water from the intracellular component out into the extracellular component. That's going to dilute out your serum sodium. Okay, so dilutional hyponatremia, aka translocational hyponatremia, if we want to sound real sophisticated. It's just something you gotta know for USMLE. So you'd select an up arrow, beta-hydroxybutyrate, down arrow, serum sodium. Now serum sodium should be 135 to 145 milliequivalents per liter. There's more medicine 301 level stuff. I'm just gonna give you a little bit more context, right, for fun, but for every increase of 100 milligrams per deciliter in serum glucose above 100, then you're going to get a drop of serum sodium about 1.6 to 2.4 milliequivalents per liter. In other words, let's say a patient has a glucose of 500 up from 100. That's a drop of 6 to 10 milliequivalents per liter of serum sodium. You understand? You don't have to memorize those numbers for USMLE, but I'm giving you some context that when the glucose goes up, that can explain hyponatremia in patients. Concept you got to know. Choice C, decreased urinary potassium is wrong. So, and choice C, increased total body potassium is wrong, so they're flipped. Okay, so you're going to have increased urinary potassium, decreased total body potassium, and you're going to have increased serum potassium. Now let me explain, okay, relax. When insulin is deficient, you cannot push potassium into cells. So normally insulin allows glucose to go into the cells via GLUT4, you get ATP production, and then you're going to get sodium, potassium, ATPase pump activation, where you pump 3 sodium out, 2 potassium into the cell. You can't do that. So potassium builds up outside the cell. Makes sense? Fine. In addition, you have something called cellular shift, where because you're producing lots of protons, it's acidic environment. DKA, it's high ion gut metabolic acidosis, the D in mud piles. Well, the cells are going to start buffering the protons, and you'll have some potassium kicked out of the cells to compensate. It's called cellular shift. So you have a mix of cellular shift, and also insulin just can't push potassium into cells. So you get hyperkalemia, okay? High potassium in the blood. But the kidney is going to sense that high potassium, and then it's going to start micturating it out. It's called kaliuresis, fancy word that means micturation, urination of potassium. So the kidney is doing what it's supposed to do. It's just seeing the high potassium in the blood, and then it's going to get rid of it. And that's going to ultimately cause low total body potassium. Okay, so you've got low potassium in your cells, you got high potassium in the blood, and then the kidney will continue to get rid of it. So what we call this is hyperkalemia despite low total body potassium. Okay, so you're going to have a lot of potassium in the urine, you're getting rid of it, you're going to have high potassium in the blood, it's low inside the cells, and then it's low total body. So you got to know these arrows for USMLE. Okay, and then increased glucokinase activity. I was just being an asshole, threw in a little bit of nitpicky stuff here, but you guys will see this on NBME exam. So glucokinase is the hexokinase variant in the liver. It's the first step of glycolysis, converts glucose to glucose 6-phosphate. So it's activated by insulin. Hexokinase isn't. So glucokinase has a greater Km, less affinity for glucose, greater Vmax, greater saturation capacity for glucose. This makes, in comparison to hexokinase, and this makes sense because when glucose levels are lower, we want the greater affinity hexokinase ubiquitously, skeletal muscle adipose tissue, to preferentially take up the glucose. We don't want the liver to do that. So the liver has a higher Km, less affinity for glucose, that glucokinase. But glucokinase has higher saturation capacity for glucose, higher Vmax, which makes sense because as glucose levels rise, we now want the liver to start soaking up all the glucose so it can be converted and stored as glycogen. Wrong fucking answer.